We're going to kick off this morning with Clory Carrello, who's the Chief Executive with Cockburn Integrated Health, who's going to talk to us about the GP Super Clinic experience. Thanks, Clory.
Thank you very much. Before I start, I'd like to acknowledge and pay my respects to the traditional owners of the land on which we meet, the people of the Kulin Nation. I wish to pay respects to their elders, both past and present, and also pay my respects to all Aboriginal people here today. What I'm going to present today is an overview of the challenges at an operational level we've faced at Cockburn Integrated Health and implemented integrated service models, and what we've done to overcome some of these challenges. Over the last couple of days of this conference, it's been interesting to listen to other presentations and note the issues we face at Cockburn are no different to other service providers. Just to give you some background, Cockburn Integrated Health has been operational for 5 years and is one of 5 GP super clinics established in Western Australia as part of the previous Commonwealth Labor Government's GP Super Clinics program. It was set up by the City of Cockburn, which is located in the South Metropolitan area of Perth. They decided to establish a not-for-profit entity to manage the operations of a super clinic and to incorporate the super clinic into the development of the Cockburn Health and Community Facility at a cost of over $50 million. The super clinic was named Cockburn Integrated Health to reflect the fact that our aim was always to achieve service integration at our site and with other services in the community. In providing funding for the super clinic, for the development of the super clinic, the Commonwealth were not prescriptive about what it should look like, only that it should aim to meet a broad range of objectives, including providing well-integrated multidisciplinary care, being responsive to community needs, and integrating with local programs and services. What you'll find if you visit each of the super clinic sites in WA is that each has totally different operational structures and service models. What we did at Cockburn, we looked at service development for the super clinic. We went through a process. We initially went and reviewed the literature and service models. There was a lot of information on integrated primary care systems, but we specifically looked at the work the WA Department of Health had done in terms of the need for service hubs in the community that could integrate with a whole range of services and keep people out of hospitals and away from emergency departments. Specifically, there was the Health 2020 report from back in 1998, and we also looked at the Health Reform report from 2004. They both spoke about the efficacy of these service hubs in the community. We then looked at the demographic and epidemiological data associated with our local population, and we'll go through some of this. We also spoke to local service providers about what they saw as the service gaps and the potential to work together going forward in addressing these gaps. This included discussions with the Government Health Service and the Child Health Services, the then GP divisions and the Medicare local staff. Strategically, the board of Cockburn Integrated Health decided we should not be a service provider as such, as we did not want to be seen to be competing with other service providers and creating another silo in the community. We also spoke to the community about what they saw as the service needs for the area. Rather than creating a new community forum, we linked into forums established by the City of Cockburn, including the Cockburn Community Development Group, which included community representatives from all localities within the City of Cockburn. We also spoke to the City's Aboriginal Reference Group. We also linked up with a not-for-profit organisation that provides services to migrants and refugees. So we use this network to get feedback from the culturally and linguistically diverse community about service provision at our site and our community. We then went about recruiting services for our site that were reflective of community needs and looked at ways of how we can make the integration work. This recruitment process included interviewing all service providers that were potentially taking up tenancies and ensuring that they were committed to what we were trying to achieve from an integration and community-focused perspective. When you look at the demographic data, you'll note that Cockburn has a young population of about 110,000 people, growth rate about 4 to 5%, lots of young families. The highest population group being the 25 to 44 age group, second largest 0 to 14. Having said that, we've got to spread across all age groups. We also have a very culturally diverse community with approximately 20% of the population not speaking English at home. In addition, about 1.5% of the population are Aboriginal. When you look at the epidemiological data we obtained from the WA Department of Health, beside the fact that Cockburn residents like to have a drink, the most significant issues for our community are overweight and obesity and mental health, with the statistics for our population significantly higher than the state averages. We work with the City of Cockburn to attract a range of services to site, ranging from general practice, allied health, pathology, child health, migrant and refugee, social support specialists, pharmacy, mental health, dental, radiology, disability and employment services. The City also co-located a library at the facility and attracted the Commonwealth to have a Centrelink service at the site. We've also got Curtin University at the Cockburn Health and Community Facility who have established student-led clinics for the community. As mentioned previously, we interviewed all service providers before they took up tenancies at our site to ensure that they were committed to what we were trying to achieve. We also ensured we did not have duplication of services, as we did not want to introduce competition which we thought would detract from our efforts for service integration. Additionally, to ensure that we were not seen as trying to compete with other local services providers, especially the general practitioners, we invited them to form a consortium to deliver services at our site. In this way, we felt that they could feel that they were part of what we were trying to achieve. We also felt that this would create an environment with other general practices in Cockburn would refer clients to our site for access to service rather than feel threatened by what we were trying to establish. Strategically, we attracted a range of government, not-for-profit and private providers to our site. Our intent was always about ensuring for access to services for the financially and socially vulnerable members of our community. The outcome has been that we have over 30 different services at Cockburn Health and Community site. From our perspective, we feel this is a very unique model in Western Australia from a co-location perspective. We then established a service provider committee and we invited representatives from all service providers at the site and other services in the local community to discuss how we could work together to develop integrated service models to address community need. The intent was always to present these models to the community through existing forums before they were implemented. We had specific areas of interest, such as Aboriginal health, youth health, mental health and chronic disease prevention and management. We had long discussions about what integration means and how we wanted services to come together and consider the overall health and wellbeing of the client. Our initial approach was about educating the service providers about opportunities to work together, but this presented a number of challenges. As can be seen we experienced a range of challenges, but very early on it was evident from it that the service had very little experience in working in integrated systems. We had governance issues, specifically about who would take overall responsibility for the clinical outcomes of the client. There were issues around having a common method of referral and client record holding. The reality we experienced was that GPs were concerned about patient confidentiality issues. The state government service were not allowed to share information. Some of the not-for-profits would not share information, and other services could not afford to implement shared IT systems. There were also issues around quality and trust, and also concerns that some of the not-for-profits only had funding for specific periods of time, so there were uncertainty if the services would continue. Cost was an issue. Various service providers noted they were not necessarily reimbursed by the Medicare system for the time spent in collaborating and integrating with other services. The GPs in particular noted the pressure to bulk bill, and anecdotally they suggested that Medicare rebates hamper integration. Another issue raised was consumer choice. This was raised by the GPs but also by the government service providers who advised that they were not allowed to, from a policy perspective, to refer clients to a specific service if multiple similar services existed in the community. All they could do was make a suggestion to the client, but ultimately it was about client choice. There were also issues around cultural security and safety of the service, particularly in reference to the Aboriginal people accessing services at the site. So what we did to overcome these issues was basically looked at specific service models, and it's still a work in progress, but what we've done is set up 3 models in particular: mental health, a model looking at overweight and obesity, and an Aboriginal health model. What we did with our mental health service model is put together a network of mental health and social support service providers that meet on a regular basis to discuss client needs. The GPs and other service providers would refer clients to the network once client had been obtained for the referral. The network group discusses the client's needs and decides who's going to coordinate services for that client depending on their needs. What we have found to be important is that the GP is provided with a report on supports and services put in place for the client and any client outcomes. The anecdotal advice is that the model works well. We're very fortunate at our site we have some very flexible services that are able to accommodate the range of needs presented by the clients, or also willing to find suitable services in the community. Some of the issues clients presented that impact on their mental health and wellbeing include family issues, drug and alcohol, parenting, employment, housing, financial and legal issues. What we've used with our mental health service model is a collective impact approach, where a range of service providers work together to provide support for the client. I recently attended a talk by a researcher from the Grattan Institute who talked about emerging trends in primary care, and he specifically spoke about network integration. I believe this is what we've tried to do in Cockburn over the last few years. When we looked at overweight and obesity, we found there were a number of programs already in the community to address this issue. We knew the private health insurers offered programs. There were some state, federal and local government funded programs. There were also private programs. We did not want to replicate these, but rather thought our best option from a service integration perspective would be to provide support to clients to access existing programs or establish new programs when we thought there were service gaps. We set up a steering committee with representation from various stakeholders to develop and oversee our programs, and they meet on a quarterly basis to review program operations and outcomes. We've been very fortunate to attract some funding through the Primary Health Network to help support the program. This enables us to employ a coordinator on a full-time basis to assist in program management and to provide support to clients. They work with nurses and nurse practitioners on site to ensure the clients receive regular health assessments and are linked into existing programs or services. They also work in developing new programs if service gaps are identified. The program's now been operational for 2 years and seen over 500 clients. What we've also done with the program is to provide support to local primary schools to provide health education to children and parents in the areas, as what we've found is that though healthy eating is part of the school's curriculum, the capacity of school teachers to provide this education is limited given the number of other demands they have on their times and efforts. There are other government-funded services that provide support for health education in schools, but what we've also found is that their capacity is limited due to financial constraints. So our efforts are focused on filling in these gaps, especially in those schools that have the most vulnerable populations. The reality for Cockburn is that we have over 30 schools, including 28 primary schools, and there is significantly more work that can be done in this level to address overweight and obesity in children. As can be seen from the slide, we have provided support to 10 local schools to provide health education to over 1,800 children, and we continue to invest options on how we can expand this part of our program. I also want to talk about the work we've done in establishing an Aboriginal health program at site. We chose this, what a lot of people don't realise, that almost 40% of West Australia's Aboriginal population live in the Perth metropolitan area. WA's got a population of about 90,000 Aboriginal people, and if you look at where they live, largest population group in the Kimberley, second largest in the South Metro area where Cockburn's located. So the anecdotal feedback we get from our local population, Aboriginal population, is they have similar issues to Aboriginal people living in rural and remote locations when it comes to access to services. Issues around costs, transport and cultural safety are commonly raised when it comes to access to care. So what we've done is formed a strategic alliance with an Aboriginal community-controlled organisation that receives funding through the Commonwealth Integrated Team Care Program. So while they provide the coordination support, we provide access to the GP and subsidised allied health, dental and support services for their clients. So this has all been done in consultation with the community. Additional to this, we have set up some specialist programs, as access to specialist services is also an issue for Aboriginal people. For example, we've partnered with various organisations to provide specialist ENT and audiology service to Aboriginal children in our area. We have found with the program that there is a significant amount of middle ear disease in this client group, and to improve access to hospital services, what we've also done, rather than putting all the children requiring surgical intervention on a government waiting list, we've negotiated with a private hospital provider to provide free access to hospital services for some of these children requiring surgical care. We've also been very fortunate with this initiative. We have a very socially conscious ENT surgeon and anaesthetists are prepared to not privately bill for their services. So just in conclusion, the lessons learnt from my experience: integration needs to be led. You can't just assume it's going to happen through co-location. You need resources to make things happen. Trust is really important. The GPs and other service providers need to be reassured about the quality of the services and at the centre of the model is the client. You need a good understanding of the services that are available in the community and how they can work to achieve your integration goals. And most of all, you need resilience, because in theory, integration sounds great and easy, but the reality is you need to work hard to get it and make it happen. Having said all this, co-location does have other advantages in that it makes service providers aware of other service options in the community and assists in forming relationships between organisations. Thank you very much.